Good morning, everyone. Uh, I'm starting my presentation after a long pause of some weeks because of festival and political condition of the country. And I'll start with the journal presentation that was published in Thoracic Surgery Clinics in 2025 August. This is the latest issue. And the article, this is the volume 35 article is based 273 to 278. And it's titled as pulmonary artery injury during the lung resection. And from the title, we can see that we are studying some navigational crisis of the pulmonary artery injury. This topic is adrenaline field complication itself for a thoracic surgeon. And the title itself provides a clear concept of what we are going to study today. The authors are Kobar JP, Stewart BP, and Wallace J. and Walters GM. Before going to the introduction and diving deep to the topic itself, the clinical significance on why the topic or why the study is needed. This is the literature review. Why the review is needed is the lung cancer is still the third most common cancer in US, and the leading cause of cancer death globally. And the PA injury is a rare but graded complication. It accounts 1.5 to 2.9% in bats to rats, and it has a similar complication in bats as well as in rats. Even though it is rare, but it is the most common catastrophic intraoperative event. It causes significant impact on outcomes, that is, increased length of stay, transfusion needs, and up to 22% in hospital mortality. And the conversion to thoracotomy are seen in 1.6 to 9% globally. So, before going to the topic, the author in their background have given the takeaways. That is, there are 4 points in this during the injury. That is, first one is remaining calm. That is our poise, which sets the tone for the OR. And then act decisively, and then be prepared. That is to have a mental algorithm and the right tools ready for the upcoming action, and know when to convert. And we should know that the conversion is a strategic decision of operating, but not a failure. And so today we'll focus on how to stay calm, act fast, and be prepared as we encounter this catastrophic injury. The modern surgery is seeing a huge paradigm shift from the open surgery to the minimal invasive surgery. Now we have the screening program which detects the lung cancer earlier, and we are having more surgical cases than ever. And due to the increased number of new adjuvant therapy, due to the proper staging, the more challenging hilar dissection are being encountered due to the fibrosis. So the central dilemma now is that we are tackling with the more difficult cases post new adjuvant and through the smaller incision without the safety of our previously used wide open thoracotomy. So this has become a challenging scenario. As Before diving into the topic, the author has given the brief description on anatomy and risk factors about the possible PA injury. And the upper lobes are the most common site of the injury. RUL versus LUL has been debated, and the interesting stats is that the upper lobe tumors are the more common tumors than the lower lobe tumors, and they have the highly variable branching patterns, large truncus branches, and difficult stable angles, as I already said. And if we see at the picture given here, the PA is coming off the right ventricle. It is 5 to 6 centimeter in length and 2 to 3 centimeter in diameter, and branches to the left and right exactly just anterior to the carina, at the level of carina. The right PA goes posterior to the ascending branch and just anterior to the right main bronchus, and left PA goes anterior to the descending branch and just above to the left main bronchus. That's how we can find the bronchus during the OR as well. So there are certain risk factors which can be divided into the anatomic locations. tumor-related risk factors, treatment-related risk factors, and technical risk factors. We'll be talking about where and why the upper lobe resection is the most difficult one for the resection. Or it has a statistically more number of the PA injury. One may be because of the tricky dissection around the posterior ascending branch of the right upper lobe, and because of the angulation that we have to do for the stapling as well. This is very difficult, and paradoxically, the upper lobe tumors are found to be very common than other lobes. So PA injuries are bound to happen. Our thoracic surgeons will see the PA injury once in their lifetime or more. Another is the tumor related, that is size more than 5 centimeter, and the large central tumors, which makes the dissection area very limited, are the patient who had undergone chemotherapy or radiation therapy, which makes the hilar dissection very difficult because of the fibrosis, makes the dissection very ductile. Or the planes may be unforgiving at this scenario. And another is the technical aspect, that is dissection behind the structure, that is suprapulmonary vein, excessive traction, and the energy devices near the pulmonary artery, and stapler misfires. Stapler misfires are usually it happens mainly in because of the angulation and angulation of the staplers and the company failure, and the energy devices due to the lateral thermal injury while dissecting around the PA is also one of the major causes of the PA injury. The another major contributing factors is surgeon role, experience, and technique. The writer has divided it into the surgeon's factor and the pulse of prevention. The surgeon factors is that the experienced surgeon are bound to manage the event very calmly, or they are bound to see the less PA injury compared to the trainees, even though the evidence are very conflicting, because some studies show a learning curve while others do not. But key takeaway is the is not the who will cause the injury, but who will manage the injury. So pulse for prevention is dissection in the correct plane, that is directly on the vessel adventitia. This is the most hemostatic plane, and that we have been taught for a while, and we should respect the tissue that is already excessive traction and blind spreading behind the vessel to make a space for a scapular. And we should see the scapular safety, that is ensure the adequate safety for the angle and optimal angulation. The posterior portion, where we will insert the anvil, will cause the injury if we don't see it properly. And for the tiny branches that is less than 5 mm, it is always better to consider the vessel sealer or suture ligation instead of the stapler. And from the author, it is the pro tip from the author is, while stapling, it is always better to have a sponge grasping instrument or instrument with the sponge wrapped around for the hemostasis. Some senior authors, some senior surgeons also use the suction device to control the bleeding and to give the traction, as well as to compress the bleeding spot if seen. Managing the crisis, the 4 P's of the managing crisis. Sarfolio et al., they have given the 4 P's to manage the crisis in the OR. The first P is the poise, which is the first step. That is the demeanor of the operating surgeon. And the OR environment will mirror our demeanor. If we are chaotic, if we are anxious, the OR will be chaotic and anxious. If we are calm, the team will be organized and function properly. A flustered surgeon will lead to the chaos and poor communication in the OR, leading to the decreased productivity in the surgery. Another is the pressure. This is the first action that we can do as a operating surgeon. And there can be various actions. That is, first one can be the immediate gentle pressure with a rolled sponge. In case of the vats or rats, that is sponge cigar is also called. We can also use the long parenchyma by the long holding forceps and use it to apply the gentle pressure on the PA. We have to keep in mind that the pulmonary arteries, they come off the right ventricle. They are very low pressure vessels, and forceful pressure can only worsen the tear. So it should be very gentle. And some of the minor superficial injury can be controlled by the pressure only for 5 to 20 minutes. And we have to always be vigilant while using the suction. The suction can be used to clear the blood around the injury and to pressure the injury site as well. The thorough preoperative imaging and CT angiography and 3D reconstruction is one way of preoperative preparedness, which is stated in an article. But the preparedness that Koirala et al. Said is during the OR. This is the mental algorithm that we have to make while facing the injury. We have to communicate with the anesthesia, saying that we have a vascular injury going on. So we have to prepare the team for the massive blood transfusion, management of the blood pressure via other inotropes or drops. And we have to communicate with the nursing team to open the thoracotomy day, as the VATS team may not be adequate or may not have adequate tools necessary. And we have to call for help for another attendings of the OR to the senior, because another hand or another experienced hand is always beneficial while tackling the chaotic scenario. And last is the escalation, final thing, that is the proximal control. If the bleeding persists, even after some techniques that we'll discuss in the next slide, even if after that the bleeding persists, the proximal controls via more dissection or extrapericardial or intrapericardial dissection to the main PA can be done. There are several options, that is the vessel loop, the double wrapping the vessel that we used to do during our VATS lobectomy, and automatic vascular clamp can be used to obtain the proximal control. And this provides a controlled field for primary repair with permanent monofilament suture in the distal site. So techniques, takeaways are the compression with sponge stick or nearby long tissue. Use of hemostatic agent for superficial tangential injuries are also shown to be very beneficial. That is fusion glue. These are the cyanoacrylate glue can also be used for hemostasis purpose for some time. And primary repair with monofilament suture, proximal control via extrapericardial or intrapericardial dissection and conversion to thoracotomy. So the repair option can be the primary suture repair if the tangential injury is seen or the injury site is seen. It is the most common definitive solution. The patch angioplasty is another. If the primary repair would narrow the vessel, then we can do the patch angioplasty. That we had done in one cases, but I could not gather the videos. We use the pericardial patch for the repair of the tear PA. We can also use bovine pericardium as well. That's also an option, but the native pericardium would suffice the patch angioplasty. Stapler ligation for the distal branches can be done. And the innovative technique, that is the suction compression, as published by May et al. From Maya, using an endoscopic suction to control and expose the simultaneous injury site, can also be done. So conversion to thoracotomy at the right times could be life saving, and the last resort should be pneumonectomy if the PFT is allowed, or if the patient can endure the pneumonectomy, or if there is a facility, then cardiopulmonary bypass is definitely the way to go for the better management of the case. So to summarize, the PA injury is the low frequency, high stake event. Prevention is the key, and we have to keep in mind that the meticulous technique, understanding the anatomy, and visualizing the 3D understanding of the anatomy is the key point during the surgery. Identifying the high risk patient is also one. And when it occurs, we should follow the surgically 4P that I had discussed, and we have to have a predefined mental algorithm and practice it with your team. While the simulation and practice may not be feasible for the third world countries like us, as given by the authors, but uh, having the mental mindset to be calm is always the way to go. And the ultimate goal is patient safety. The oncological resection can be completed once the crisis is management. This should not be forgotten. So, in very short, if I have to, I went through the article, and if I have to say the articles have certain strengths and limitations, and the key takeaways that we can apply in our clinical scenarios. The strength of the article is it is a very concise, practical, and written by the experienced surgeon, and it provides a clear, actionable framework. The 4Ps given by the surgery et al., who had done more than hundreds rats already, and it synthesizes the recent literature on topic where the large trials are impossible. We cannot include the PA injury into the trial because these are the emergency setups and emergency unanticipated scenarios. And the major limitation is that it is based on the retrospective data and the expert opinion, which is the lowest level of the evidence if we have to talk about. And no new primary data is presented. It is a review article from 2016 to 2023, and the conflicting data and surgeon experience versus the expert surgeons versus trainee who will cause more injury is still unresolved. The data are very conflicting, and that's all. Thank you. So these are the major references that Sarfali et al. From Annals of Thoracic Surgery 2016. The main portions are taken from the latest article of the Koirala et al. And Sear et al. 2000.
Of the artery anomalous congenital variations in the pulmonary where in this condition the left PA is arising from the right P, from right pulmonary artery, and it's going in between sandwich between the caption and the this context the patient might be having other anomalies also, including the cardiac problems, cardiac malfunction, maybe there. And tracheal bronchopneumonia, tracheal bronchopneumonia. So your chances you just can another visit with it. Because during surgery, if you are carrying out a left nose procedure, you must be doing good, you will be digging inside and you will not be finding the pulmonary artery proper position. The very huge jam and income clearly were formed pulmonary artery and the CT scan study. So during terminology, this pedalurium is not for the pulmonary artery, that's for the average left subclavian artery. So it passes between the tracheal compression ratio factors. Then, just like I'm a patient, you will have finished when say, but this pulmonary artery also. You touch it and after pulmonary also, the next very important thing is that why CT scan is important. We are talking about the lobectomy, the open lobectomy. So let's take a scenario. Example, say your right side to pulmonary artery. So divide it into the superior trunk, the trunk interlobar artery. Let's suppose we are planning to the right upper lobe. Sir, upper lobe. And the right upper lobe might turn to superior artery also. You announce the A3 also. When you found during surgery, this is 3 segments. You and the fisher artery also. And the upper lobe like the supply artery is around except the interlobar artery, but it's so you found it during surgery, there is some of the branches, this is the middle lobe artery, and some of the branches going up to the secondary angle clearance. From the middle lobe, we return lobe C and the middle lobe artery. So what is this? When you artery divide now, middle lobe interlobar artery, यहाँ पर middle lobe artery या middle lobe left side, यहाँ पर artery shoot up by as the upper lobe. Where will you divide that artery? Will you divide it here? Or will you divide it here? So when you divide it here, this is the ascending A3 artery. that has not come from the peritrunk, but that has come from the truncus in the interlobar artery, truncus in failure. So you can even during lobectomy, we may be confused. Coronary artery don't know position much right. And so when Anjana Zuri one, you can't like it. What's this? You have to name that artery that is coming from the middle of artery scenario. Therefore, situation after coiling analyze this reconstruction and coiling analyze also. So after I took my phone and studying the subsegmental anatomy, I found that's very important thing reconstruction. But you recognize each and every details of the arterial system. So far we are concerned with the arterial system. Because you Jana is one of the forms in Amriti, okay? Because when we A3 artery, obviously it may be coming from the A4. So similarly, application upper rectum very nice. And upper local. What we found with this interlobar artery has and A6 artery has one of the branches going to the A3. Yes, so you're pretty known phenomenon, known variation just like it. A2 artery and posterior ascending artery, sir, that arises from the AC. So you have to do that also. You the lobectomy use bravo, right? यदि हामीले सेगमेन्टेक्टोमी गर्दा छ त्यो जान्ने चाहिँ एकदम छानले जरुरी छ वान इज सपोजली उसको लबेक्टोमी गर्दाखेरि मोटामोटी हामीले जान्न सक्छौँ हैन त सेगमेन्टेक्टोमी गर्दाखेरि झन् अझै इम्पोर्टेन्ट सिनारो जुन एकदम कमन स्ट्यान्डर्ड इन्क्लुड मेडिएसन ट्याक्ट हामीले चाहिँ लेफ्ट साइडको पल्मोनारी आर्टरी लेफ्ट साइडको पल्मोनारी आर्टरी कसरी आउँछ एक्सरमा यो लोअर लोब यहाँ हुन्छ लोअर लोब यो चाहिँ अप्पर लोब सेकेन्ड आन्सर लेफ्ट साइडको पल्मोनारी सो द फर्स्ट ब्रान्च दैट कम्स टु द A3 ब्रान्च राइट जनरली A3 हामीले एकदमै हामीले आउट अफ अल द लोबेक्टोमीज अर सेगमेन्टेड द लेफ्ट साइड अप्पर लोब फर मी इट्स मोर कम्प्लिकेटेड द more variation multiple arteries are there even for the lobectomy also. So A3 artery पहिला सुरु गर्छ usually aspirate like usually generally common but it's not always like that. A3 छ भने A3 interlobar artery माथि सुरु हुन सक्छ that is called the ascending type यताबाट आएको interlobar artery तर एउटा कमन मिस्टेक के हुन्छ भने यहीबाट लिम्फोइड आर्टरी आउन सक्छ आउनु पनि यहाँबाट हो A4 A5 A4 A5 but if माथिबाट resection type आछ that interlobar surgery if you limulate to the person you will choose the arteries well yes during surgery if you find absent A4 or A5 or both nothing you don't see any branching going towards the lingular so you must be keeping in mind that this artery is arising from the main trunk from in the clinic as the military type lingular artery and if you are not sure of that you can demonstrate in video such that will call force the pulmonary artery injury again. Very segmental anatomy artery beforehand you CT scan recognize this when two CT scan you goes on this type of anatomical variation. केवल examiner पहिलो कुरा चाहिँ के जरुरी भयो भने कि साँच्चै मेजर कन्जेनाइटल एनोमली छ जस्तो पल्मोनरी दोस्रो यदि सेगमेन्टोटोमी जानु छ भने त्यो 3D reconstruction नगर्ने टुटीलाई proper study गर्नु you can identify well there is the pedestrian type. Whereas maybe A2 is coming from the A6 in the right side. Example, A7 that is coming from the interlobar pulmonary artery coming from maybe A8 plus 9. त्यो पनि anomaly हुन सक्छ. यस्ता अब A6 जुन चाहिँ A2 बाट आउन सक्छ. यी सबै कुराहरु हामीले pre-operative CT define गर्न जरुरी छ. That in this mishap was there one of the things that will make you answer there. And pre-operatively, I have to determine the so on the basis of CT. We don't have many things, so on the basis of CT scan, you can find out that one. And take home message like the purely ekdam राम्रो मलाई लाग्यो 4P हरु लेखा छ नि very good. हामीले एकदम पेशेन्ट राखेको छ very important thing to when to convert. कतिसम्म वेट गर्ने. One of the sentences मा उले लेखा छ कि we have to expose the pulmonary artery where if you have pressed it a lot of bleeding that generally away from the pulmonary artery you have to do either intrapericardial or extrapericardial हामीले एक्जम्पसन पहिले पनि गर्नु जस्तो कि याद छ तपाईले लोबेक्टोमी गर्दाखेरि अप्पर लोबेक्टोमी गर्दाखेरि इन्केसमेन्ट छ भने before landing into the throat. पहिले नै control गर्ने. This is very important to the left side rather than to the right side. लेफ्ट साइड मोटो छोटो आर्टरी ट्रङ्कहरू हुन्छ जो इन्जुरी हुने चान्स बढी हुन्छ. त्यस्तो छ भने त्यो इन्जुरी एभोइड गर्न लेफ्ट साइडको पर्टिकुलर पहिले नै लेफ्ट यसलाई स्लिङमा लिने. इफ समथिङ ह्यापन्स यु हेभ द कन्ट्रोल अफ द हार्ट. त्यो लेफ्ट साइडको लागि भेरी इम्पोर्टेन्ट छ. लेफ्ट साइडको लागि थ्योरिटिकली टेक्स्ट बुकहरूमा के लेखेको छ भने यदि अप्पर लोबेक्टोमी गरेको छ भने पहिला लिगुलर आर्टरी बाँध्दै जानु रिभर्स वेमा and from the upside because the most dangerous is A3 and A1+2. त्यो एकदम छोटो हुन्छ दुईटै कम्बाइन्ड वेमा आएको हुन्छ सर. त्यो चाहिँ जान्न जरुरी हुन्छ. लेफ्ट साइडको लागि हामी आशिषले नै भन्नु त लेफ्ट साइडको लागि कतिवटा आर्टरी हुन सक्छ. एउटा A3 भयो. अरू फर्स्ट ब्रान्चको चाहिँ सेकेन्ड द्याट्स मोस्ट क्लोज. त्यसपछि नाउ देन कम्स A1+2. जेनरली के हुन्छ भने लेफ्ट साइडको लागि A1+2 A+B कम्बाइन्ड हुन्छ र A1+2C सेपरेट हुन्छ. बट यसो दुईटा ट्रङ्क भयो तीनटा ट्रङ्क भयो. सबभन्दा कम्प्लिकेटेड सिनारियो कस्तो हुन्छ जो कि A3 र A1+2 A+B टुक्रीबाट आएको एकदम सर्ट ट्रङ्क हुन्छ. इजिली टियर हुन सक्छ, रप्चर हुन्छ. त्यो चाहिँ एकदम केयरफुल हुनुपर्छ. भेरी इम्पोर्टेन्ट पोइन्ट उहाँले के भन्नुभएको छ इन द फ्याक्ट्स वी एप्लाई द स्ट्यापलर. म चाहिँ अहिलेको सिनारियो मैले के सिकेँ भने स्ट्रगल नगर्नु. यदि तपाईँको हाम्रो लङ्स चाहिँ विदेशीको इभन चाइनिज लङ्स जस्तो छैन नोट्सहरू हुन्छ स्ट्यापलरले यति स्पेस ओपन त गर्नु पर्यो. एटलिस्ट 1 सेन्टिमिटर or more than 1.5 centimeters should be a space in order that you can pass the stapler jaw of the strap. There are several companies who has come up with the narrower jaw जो कि सानो डिस्टेन्सबाट भयो 8 mm को छ. अहिले हामीसँग अवेलेबल भएको 10 mm कि 12 mm को जौ हुन्छ. त्यो चाहिँ एकदम न्यारो हुन्छ, थिक पनि कम हुन्छ, पातलो हुन्छ र 8 mm को हुन्छ. 8 mm को लेन्थ विड्थ र पातलो. त्यो भने इजिली पास गर्न सक्छ भनेपछि लेस ट्रबल भयो. सेकेन्ड चाहिँ अहिले नाउ फुल ब्राइट कम्पनी छ. उसले 90 डिग्री एङ्गुलेसन गर्छ. कुन कम्पनी? त्यो चाहिने यो फुल ब्राइट. फुल राइट कोभिडियन उनीहरूले 35 कि 45 कि कति 50 डिग्रीसम्म मात्रै एङ्गुलेट गर्छ भने चाइनिज कम्पनीबाट निकालेको 90 डिग्री एङ्गुलेसन गर्छ. द्याट्स मोर कन्भिनियन्ट. हामीलाई कहिलेकाहीँ स्ट्याबलमा एङ्गुलेसन नभएर प्रब्लम भइरहेको छ. 90 डिग्री भयो भने त जहाँ पनि घुमाउन सक्यो नि. त्यो चाहिँ पायो भने स्ट्याबलरको टेक्निक. मैले के सिकेँ भने वी हेभ टु डु टु थिङ्स. If you are not enough opening the jaws, creating the space, it's better to like it than to pass the stapler. Second, clips generally avoid distally, keep it proximally. Because if you apply distally, what happens? You apply inside the parenchymal bone for the staple. If it comes over the clip to your hemolar clip, it will not fire. And misfire the chance for it. Typically, have the chance of to intraoperative certain things जो कि हामीले यदि चाहिँ तपाईलाई लाग्छ कम्प्लिकेटेड सिनारियो चाहिँ कन्ट्रोल पहिला लिनु rather than त्यो प्रोक्सिमल कन्ट्रोल यो डिस्टल कन्ट्रोल स्लिप गर्नु चाहिँ एन्जियोप्लास्टिकहरू हुन्छ. यो धेरै राम्रो टपिक किन हामीले एफरेट चाहिँ पल्मोनरी आर्टरी टियरबाट हुनुपर्छ. अनि पल्मोनरी आर्टरी इज थिनर देन द भेन सो इन्जुरी ह्यापन्स क्वाइट. र म जहिले पनि भन्छु त लाइकेट गर्दाखेरि नपाउने एब्डोमिनल आर्टरी इजिली टियर हुन्छ. नट सुड बी एट द सेम प्लेस. डोन्ट मुभ हियर एन्ड देयर. प्रेसर सुड बी लाइक द नट किन एब्डोमिनमा तल माथि गरे पनि खासै टियर हुन्छ तर पल्मोनरी आर्टरी टियर हुन्छ. त्यो चाहिँ प्रेसर र धेरै एब्डोमिनमा त चित्त पार्ने टाइप नगर. जस्ट जेन्टल. दिस इज द हाई फ्लो very high volume low pressure. Yes sir. अनि त्यही हो. अरू केही भन्नु छ तिमीहरूलाई? यो इम्पोर्टेन्ट टपिक लाग्छ. हामी पनि फेस गरेको धेरै इन्जुरीहरू. एउटा पेसेन्ट हामीले घुमाएको छु ब्रिडिङले कन्ट्रोल भएको. यसो चाहिँ मलाई थाहा छैन. ब्रिडिङ धेरै भयो इन्ट्राअपरेटिभ म्यासिभ कल त्यही पेसेन्ट हो.
रिएक्ट गरेको पहिला लोबेक्टोमी
स्लिप गरेको
सोही रप्चर हो तर के गर्ने
फिस्टुला भएको
ल ठिक छ. तिमीले बाहेक तिमीले सिक जर्नल प्रेजेन्टेसन कसरी गर्छ लास्ट क्रिटिकल एक्टर्सहरू लेख्यो त्यो जरुरी छ. उसको चाहिँ स्ट्रेन्थ के हो त्यो आर्टिकल तिमीलाई